afternoon, everybody. I'm really happy to be here. Wonderful audience to talk to because, as was mentioned, pediatrics often isn't thought about in the conversation a lot of times in many different aspects of health. Yet we, and you'll see in this talk, how prevalent nutrition and the decisions we make about nutrition are to pediatric health in this country, and how those eventually turn into adult health issues too. So I am trained as an epidemiologist. So I am a pediatric, I'm a professor of epidemiology, and I am a center director for pediatric population health. So I have spent my entire career basically focused on pediatric obesity and cardiometabolic health. So I've woven in some of the national statistics as well as some of the local work that I've done over the years to show you just how important obesity really is to pediatric health. So my 4 objectives for this talk are to define the standard operational definition of normal weight, overweight, obesity, and severe obesity in the pediatric population in the United States, describe our current obesity trends, and then demonstrate the relationship between childhood obesity and adult obesity, and then finally identify some potential public health solutions to abate the current childhood obesity trends that we are seeing. So to start off with, the definition of childhood obesity is different than adults for 2 specific reasons. 1, children are growing, and therefore we have to take into account their age and their sex, always. So therefore, we have to use what we call a percentile curve from birth up to age 18. And by using that curve, we have several different groups or categories that children would fall under. So a child who's underweight would be considered less than the 5th percentile. A healthy weight child is one that is from the 5th percentile to less than the 85th percentile. Overweight is 85th percentile to less than the 95th percentile. Obese is equal to or greater than the 95th percentile. And unfortunately, just in the past several years, we have a brand new category called severely obese. And those children are equal to or greater than 99th percentile, or have a BMI greater than or equal to 120% of the 95th percentile. So if for those of you in the audience that have children, this chart probably looks familiar, because every time you go to the pediatrician, your family pediatrician plots your child's body mass index on this chart. There's a blue one for boys and a pink one for girls. And so the height and the weight that they take in clinic is then converted to a percentile curve distribution. And here you can see some examples of how children fall into the curve. So obviously this green part is where children should be. For example, here, a 10-year-old boy with a BMI of 18 would be in the healthy weight category, or between the 5th and the 85th percentile. Then you have a child down here who's actually below the green, so they're in the underweight category. We get into the yellow zone, those are our overweight children. So they're above the 85th, but they're still below the 95th. And then where we start talking about obesity and severe obesity are these children that now are above that yellow territory and up in here. And this is where you'd see, for example, a 10-year-old boy with a BMI of 23 would be in the obese category. So their BMI would be at the 95th percentile or greater. Another interesting aspect of this curve is this right here. And this is what we call adiposity rebound. And this is the healthy growth curve for any children. Usually between the ages of 3, 4, 5, 6, 7, they hit this rebound. And that's considered healthy, normal. But what we have seen in more recent times is no rebound at all, and instead just linear growth from birth straight through, which research has bared out is a risk factor for obesity even before adolescent age. So overall, if we take a snapshot of the United States using the National Health and Nutrition Examination Survey data from 2015 and 16, we see overall for obesity about anywhere from 18 to about 18.5% fall into the obese category. So almost 1 in 5 children are considered obese in our country right now. So you'll see a little bit of a difference here by age. Younger children in the dark blue are 2 to 5 years old are less than older children, but still around 13 to 14% across genders too. And then obviously as children age, we see the increases, a slight decrease in boys as they get older, but a sharp increase in girls. And so if you think about this now in history of the United States, not just a snapshot of 2015-16, the picture becomes a lot more striking. And that's when we start to think about lifestyles and how they have changed: nutrition, physical activity, built environment, and so on. And what you see from this slide are the striking changes in the obesity epidemic for all populations in the United States from the 60s all the way through to 2018. And just this sharp upward trajectory through the 70s, 80s, 90s, and 2000s. And we continue to see that even in the severe obesity age group. So it's very alarming that we've seen this increase, but also that we have seen no decreases at the same time. So I want to present a framework that this is how I teach my students too, and thinking about obesity throughout the life course, because we in pediatrics cannot think about children in a vacuum, because for the most part, children throughout their first 18 years of life depend on their parents or caregivers for their care. And that includes their nutrition choices, their physical activity choices, and so on. And therefore, we need to think much more about a family-based model and what is going on in the household. And that may also include older adults. In a lot of our ethnic families, there are multi-generations living in one household. And many times the grandparents are doing a lot of the cooking in the house for the younger children. And a lot of times the moms depend on their moms for nutrition advice also. So it's really important to think about how obesity impacts every aspect of human growth and development. Starting with pregnancy. So this map right here shows now in the United States the prevalence of pregnancy obesity. And if you look at the latest statistics in 2019, almost a third of women enter pregnancy with obesity. So we're talking one in 3 women. And you can even see in places like Arkansas, it's even higher than 1 in 3. So we have to start thinking about even from conception, how obesity may potentially be impacting the health of that child. Some fascinating literature. Probably some of you have read about the thrifty phenotype hypothesis, Barker hypothesis. There's all sorts of names about thinking very broadly about perinatal exposures and how they could lead to future health risks. And some of the earliest work in this area comes out of the UK, and looking at women's and how they ate and their nutrition intake during pregnancy, and how that in fact impacted not only the birth weight and the birth outcomes of their child, but the future cardiovascular risks of those children. And the earlier studies done by Barker have shown that babies that have been restricted in growth in utero and maybe born small for gestational age go on to actually develop high blood pressure at very young ages. So I give a whole course in this. It's doing it no justice on one slide, but I think it's really important to bring up in context to this conference and thinking about how we address pregnancy nutrition also, and thinking especially now that we have about 1 in 3 women that are entering the pregnancy with obesity too, changes that paradigm a little bit. We also have to think about obesity during pregnancy and how it is impacting mom's health. So the risk of miscarriage for a normal weight mom is about 1 in 5 or 20% by 12 weeks. But it increases to 1 in 4 for women that have a body mass index greater than or equal to 30. There's research that's shown that this is also related to cancer risks, excess fat, which is, secretes hormones, so such as estrogen, which therefore increases the risk for cancer. And there's been a lot of studies that have bared out this and shown that there's a 10% increased risk of ovarian cancer for every 5-unit increase in body mass index for a woman. And there's a 12% increased risk of breast cancer in postmenopausal women for every 5-unit increase in body mass index. So there's multiple risks when mom has obesity when she's pregnant to both her and her baby. Fascinating literature in this area that's shown mental health impacts, including depression and anxiety. The odds of having depression during pregnancy are 43% higher than a mom without obesity during pregnancy. Postpartum depression also at a 30% higher risk. Anxiety at a 41% higher risk. Gestational diabetes increases by almost 1 unit with every 1 kilogram increase of BMI. Gestational hypertension increases by 2.5 to 3-fold. Preeclampsia doubles the risk with every increase 5 to 7 kilograms in body mass index. And finally, a prolonged pregnancy is double the risk, which that would be above 41 weeks, which brings its own medical risks with it as well for a mom with obesity. And then when we're thinking about baby, there has been research shown that there's an increased risk for congenital anomalies and neural tube defects in particular, a 2 to 3-fold increase for macrosomia or large for gestational age, which would be at 40 weeks, 9.4 pounds for boys and 9.1 pounds for girls. There's an increased lifetime risk for diabetes, heart disease, and obesity in the baby now also. So here we go with thinking about that life course model and the intergenerational effects now that are potentially happening because of obesity. there's a 1.5 to 2-fold increased risk in spontaneous, extremely preterm delivery. So those are the little 22 to 27 week babies that don't even get into a third trimester. And this is also dose dependent by body mass index. So you have this very interesting bimodal distribution in terms of either having a risk for babies born very early or late because of obesity during pregnancy. And then finally, an almost 3-fold increased risk of induced preterm delivery, dose dependent by body mass index. And if we think about this perinatal period, which the World Health Organization defines as the period between 22 completed weeks, or about 154 days of gestation, and 7 completed days after birth. So within the week after birth, for these babies that may be born large or small, there's still an increased risk for intrauterine growth retardation, increased risk for ending up in the NICU, staying in the NICU because of health problems, increased risk for cesarean section, and an increased risk for not breastfeeding. So if we move now into when we think about early childhood and include that period along with pregnancy in the field, this has now been defined as the first 1,000 days of life. So obviously that includes pregnancy, infancy, birth to 6 months, and then toddlerhood, so up to 2 years old. And when you think about how important nutrition is to this first 1,000 days of life, it goes well beyond just physical growth. And you can see down here in the bottom part of the slide, the impact of good, high quality nutrition in early life can impact so much more than just those early days. Research has shown that children who get the right high quality nutrition in their first 1,000 days are 10 times more likely to overcome the most life-threatening childhood diseases. They complete almost 5 more grades of school. They go on to earn 21% more in wages as adults, and they're more likely to have, as adults, to have healthier families too. So this, again, we have to remember, not be only thinking about the pediatric years, but how what's happening in the pediatric years is going to impact the adult health and years as well. As we move into preschool, which is roughly defined as ages 2 to 5 years old, right now in the United States, 1 in 8 preschoolers have obesity. Children who are overweight or obese as preschoolers are 5 times as likely as normal weight children to be overweight or obese as adults. And that's a really important point, in that an adult just doesn't suddenly become or have obesity at age 18, 19, 20, 21. This, for the most part, has been building all through childhood. And in the majority of children that we see, it doesn't go away, but it can actually, in fact, get worse in adulthood if it's not treated and taken care of. So if you remember back to the first slide I showed you of this, again, thinking, okay, ages 2 to 5 in particular, we're still talking almost 15% of children. And this is the latest data from the United States, 2015-16. But you start to see this upward trajectory again, and you think of, and I'll show you in a few minutes, what we see in adulthood, it just keeps building. Another big theme, unfortunately, in childhood obesity is ethnic group disparities. And unfortunately, the COVID epidemic has, in some ways, it's good that it's highlighted these disparities, but in others, it's shown just how much more work needs to be done in this area. But these are just really striking. So if you look at the dark blue, these are non-Hispanic white children. This is 2015-16 data, about 14% have obesity. But then you look at non-Hispanic Black and Hispanic children, and it's exponentially more. This is Asian children. And then we look at boys and we look at girls. And in particular, Hispanic boys, almost 1 in 3 have obesity, or roughly twice as many as non-Hispanic white boys. So some analysis that my team and I did last summer, taking the latest NHANES data, we some of the work I do is in the subgroup of children that have severe obesity, or if you remember that group that's way out there on the tail, 120th percentile or above the 95th percentile, to see what was going on with that group. And it's even more striking, not only the increase, but the disparity. So the blue line here in the middle is the aggregate. That's every child in the United States. But then when we stratify by race ethnicity, it's unbelievable almost that up here you see Hispanic, non-Hispanic Black, and here non-Hispanic white and Asian. So not only do you see this disparity, and it's going up, and remember too, this is before COVID, but again, ethnic minority groups being so much higher than non-Hispanic white and Asian. So if we start looking a little bit past late adolescence, teenage years into what we call young adults, could be 19, 20, this is 20 and over, we see the same theme, just continuing on. And this is, again, why it's so important to think about the life course approach. And we still see the same disparities, although what we are starting to see is non-Hispanic whites now catching up. And the statistics just getting, in fact, higher, to the point where in some groups now, non-Hispanic Black women, over half of the US population is obese or has obesity. And if we look at this in terms of a time trend or a secular trend, think back to that slide I showed you with children. Here's youth, and tracking right with the youth are adults. So again, remember we started back in the 60s. This is just the past 20 years, and we're still seeing an increase. But in adults, we're seeing the same. We're seeing about a 10% overall increase over the past 2 decades in obesity. Okay, so I want to switch gears a little bit and talk about why all this epidemiology, why is it important? Why do we care how many children in the United States have obesity? Well, many of the medical consequences of obesity were not even seen in childhood a few decades ago, and now are highly prevalent in pediatrics departments all over the country. There's special clinics now for a lot of these medical conditions you see on this slide, just to see children that have these conditions. So virtually obesity impacts, because it is this state of inflammation, impacts every system in the body, and in a negative way. So I've done a lot of my own personal work in what we call the metabolic syndrome. I'll show you another slide of that in a minute, which includes this plethora of risk factors, not just one, but elevated blood pressure, insulin, lipids, and so on. But then we've also seen many children with early stage osteoarthritis, joint pain from carrying around excess weight for so many years. Gynecological abnormalities, polycystic ovarian syndrome is one now that there's a lot of clinics for girls that have this condition. Non-alcoholic fatty liver disease is another one that's highly prevalent and unfortunately very hard to detect early on, but is an early stage risk factor that it starts very early. And it's hard to detect in children in particular. And then pulmonary disease, obstructive sleep apnea is another very prevalent condition in children with obesity. And unfortunately, the cumulative effect of having these conditions throughout childhood can then, of course, lead to adult disease, including a lot of different cancers. So as I mentioned, metabolic syndrome is this constellation of risk factors that starts with the obesity, but it also includes insulin resistance, hypertension or high blood pressure, dyslipidemia, particularly triglycerides are elevated, HDL, cholesterol is low. And then, as I mentioned, just in this general pro-inflammatory state, which isn't good for health in general. And what does this do? These are all risk factors for prediabetes, diabetes, and cardiovascular disease. So we are now starting to see overt type 2 diabetes in teenagers too, and definitely elevated blood pressure in teenagers as well. So what are the implications of this? Probably that we're now going to start seeing many more adults at a younger age with, again, complications from overt type 2 diabetes and heart disease. Some work that I did very early on in my career, and remember the takeaway from this slide, this was published in 2008, so almost 15 years ago. And even back then, doing analysis on data from the United States from 1999 to 2002, we were estimating the prevalence of the metabolic syndrome in US 8 to 14-year-olds. And our results were striking. We found that among 8 to 11-year-olds who had obesity, almost 10%, which equals about 1 million children, had the metabolic syndrome. But then when you just went up by a couple of years in age to 12 to 14 years old, it rose to 44%, which equals over 3 million children back 15, 20 years ago, who, because of having obesity, also had the metabolic syndrome. And we went on to, we went on to publish a whole book on this topic because at the time, in the early 2000s, there was still a lot of debate about whether metabolic syndrome even existed in children, which is hard to believe now. But we went on to write one of the first books about each chapter dedicated to a specific other health problem that was associated with pediatric metabolic syndrome, including, like I said, osteoarthritis or mobility problems, respiratory issues, fatty liver, pregnancy-related issues, and even mental health. So, why is metabolic syndrome and other health-related issues important in childhood and its association with obesity in childhood? Because, as we said and as we saw, they're related to heart disease and diabetes. So if we look at where is diabetes the most prevalent in the United States, we see this nice little belt in here. And this is the percent of adults who have ever been told by a doctor that they have diabetes in 2017. It's over 12% in many of these southern states. So very, very high. And if we look at heart disease death rates, of course, they're going to overlay right on top of those prevalence estimates. Same area, same geographic area. And we think about the theme a couple slides ago of health ethnic group disparities. We know there's so much research that shows how much access to healthcare disparities also happen in this same area of the country. And then finally, the parallel prevalence with overall mortality. So the takeaway message from all of this is that you can see this progression from having obesity as a very young child throughout childhood, now having health conditions that are specifically precursors to heart disease, to diabetes, and ultimately leading to mortality. And for the first time several years ago, now, I think it's been 3 cycles of data, the life expectancy has actually decreased in the United States. And a lot of people are thinking that it may be directly attributed to obesity. And if we look at preventable causes of death in 2010, obesity is quickly overtaking smoking as the US #1 killer. And some have even stated that obesity is becoming such a problem that it's compromising all the benefits of recent improvements in healthcare and medical breakthroughs. So we are clearly, by all thinking about diabetes, heart disease, especially overtaxing the healthcare system, with people now hitting the healthcare system earlier and earlier with these really complicated health issues. Diabetes is a very tough disease to treat, so it needs very intensive care. Same with heart disease. It's not, you don't go to the doctor just one time. Okay, so when we think about the etiology of obesity in the US pediatric population, or the potential causes. So again, we come back to this theme of health disparities in childhood obesity, and we saw that ethnic groups, in particular non-Hispanic, Black, and Hispanics, are disproportionately impacted by severe obesity in particular. We've seen in the COVID pandemic that people with obesity, adults and children, have a higher incidence of both death and disease from COVID-19 disease. A study that was published a few years ago in the New England Journal of Medicine showed they did a simulation study where they took children who were obese, had obesity from a very young age, as young as 2 years old, and projected out to age 35, what were the chances that they would still have obesity at that age? And the takeaway message from this is that the longer a child has obesity from ages 2 to 18, the higher the chances they are pretty much guaranteed to be obese at age 35. But another message here is, again, if you look at the disparities here, and you see in the slide I showed you earlier with the severe obesity trends, here you see the same exact thing with Hispanic and non-Hispanic Blacks being much higher than white and others. So this is where it all comes together in terms of thinking about how important it is now to address this in childhood and not put it off and think, oh, that a child's just going to outgrow it. It's baby fat, no problem. They're going to be healthy as an adult. The research has definitely not shown that. And so this is where it gets really interesting. And some of the work that I've done in the field with preschool families, especially from low income backgrounds, all ethnic minority groups, we have asked parents what they think their child's weight is. Is it healthy? Is it not healthy? And we did this by looking at having them look at a silhouette chart of different shapes of what their child looked like. 94% of parents with a child who had obesity from ages 2 to 5 years old told us they were completely normal weight. So this brings up the whole issue of now we know as professionals the child has a healthy weight challenge, but the parent doesn't see it at all. So what do we do in clinic as pediatricians, as health professionals, to work with that family to get them to understand that maybe their child has a weight challenge that we need to address together?
About 5 minutes, Dr. Masai.
Okay, thank you. So another study we did was we looked at the country of birth and of the parent, and we found that those from out of the country actually were much more likely to say that their child was normal weight when they were not. Among Haitian children, we found too that I did this work in Miami, Florida, that for every year a child comes and stays in the United States, there was a almost 4% BMI percentile increase. Yet for Healthy People 2030, this is what we are actually supposed to be looking like as a country in terms of bending the curve for childhood obesity. And clearly we're going in the wrong direction. And so here's where we have to start thinking about, okay, what are some barriers and potentially strategies for obesity prevention? And this is really where the culinary medicine world comes full frontage and can really make a big difference. Because we have to think about, especially like in the CDC framework, again, obesity is a multifaceted disease. Its causes, our roots are in so many different areas, but the main ones are food and beverage intake and physical activity. When we think about physical activity, 2 out of 3 children don't get any daily physical activity in this country. We're coming out of an epidemic where everybody was locked in their house. So we're expecting things to probably be even worse. Almost 96% of elementary schools offer no physical education. And screen time, it's not TVs anymore, it's phones that children are spending the majority of their time on rather than being physically active. A lot of really interesting work going on in nature, exposure to nature, parks, the park spaces, and how they may be a part of the solution too, in terms of getting children more active and outside. Children just don't spend a lot of time outdoors anymore either, especially over the past year. Our built environments, no surprise that many of our urban areas are not conducive to physical activity. And we have many unsafe neighborhoods too. Parents will tell us all the time that they don't feel it's safe to let their children outside to be active or to garden. And here's some examples of Los Angeles parks. It created a great Parks After Dark program, which includes gardening programs and definitely physical activity, where it's a safe space for communities to go and be more physically active, and thinking about, again, sort of farm to fork nutrition models also. Definitely, I'm sure it's no surprise to anybody in this audience that many parents are just nutritionally uninformed. And you think about how much the USDA has changed its food model. It was radical. It's gone from the food pyramid to my plate, and how much all the food items have changed too. It's a lot for parents to absorb in a short amount of time, but we expect them to. This is what we see pretty much every store we go into, and we expect parents to make healthy choices for their children. Advertising is targeted at children in particular. And this is just what we see, these scenes everywhere in America. And so this is what parents are faced with every day, especially to working parent families. Food deserts and swamps are disproportionately in lower income areas. And again, thinking about out-of-the-box programs, bringing farm to fork more into inner city areas, may be a solution. And then finally, I wanted to mention, a lot of times we hear in clinic, children just don't drink water. They don't like it. They've just always been exposed to sweetened beverages, whether that's soda or others. Just drinking water can be a basic that is overlooked, but can be a great strategy. So finally, just circling back around and thinking about how important the life cycle is and all of this. I'm looking forward to talking to everybody about it more as we get into discussion after